of being a pharmacist than you would necessarily AML or ALL or even CML, because those patients tend to be managed, either by a bone marrow transplant team, or they have specific treatments that they're receiving inpatient that are probably going to be so specialized that you may not see those patients very often. All right, so please choose the correct statement regarding MDS. So MDS is myelodysplastic syndrome. So which of these statements is correct?
B.
That's right. So etoposide and epirubicin, unfortunately, the way in which they cause DNA damage can lead to these myelodysplastic disorders, because it can essentially cause so many DNA damaging mutations that the clonal expansion of these red blood cells and white blood cells can become defunct. And you can also end up having like a series of deletion mutations and things like that can occur. It's a really insidious disease, and unfortunately, we really tend to see it more among women who've had breast cancer treatment. So I used the example of Robin Roberts in the module, and she's kind of a classic example of someone with MDS. So she had breast cancer. She received dose-dense AC and Taxol, had a complete recovery, remission from the breast cancer. And then a couple years later, if that, it may have even been only like a year and a half after that, she started feeling really run down, was bruising easily, getting sick constantly. And they started doing some investigation and found out, wow, you have really low platelets, you have really low white count, something globally is going on with your bone marrow. And so she, of course, had to undergo a number of different therapies, including chemotherapy directed at the MDS, and then going through a stem cell transplantation, which is really, they commonly fail, or patients have to have multiple of them. But in her case, she was really fortunate, and she was able to recover from it. Personally, I have a good friend who had salivary gland cancer, didn't have any chemotherapy, was exposed to some pretty intense radiation therapy, which is common for head and neck cancer. And he developed MDS a couple of years after that as well. So, there are a number of different kinds of things that can cause MDS. And, being able to identify somebody's risk factors associated with it when they're consenting for treatment initially is really important. So, for example, whenever I consent women, particularly with breast cancer, or somebody who's receiving a therapy that may increase their risk of MDS, I make sure to include that in the consent and say, hey, just so you understand, there's a possibility for something that we call secondary malignancies later on. For a long time, MDS wasn't even considered a malignancy. It was considered a pre-cancer. And we've now really shifted gears, and we know that that's not true. So, it is true that patients can transition to AML, right? Which is really bad, because AML tends to have a much poorer prognosis, needs, usually many rounds of very toxic chemotherapy, and patients often will die from the side effects of the chemotherapy before they can even get to a stem cell transplant, or they'll die because they have a stem cell transplant. So, obviously that transition to AML is something that we're very concerned about. Now, the median age at diagnosis is about 76. One of the problems with that is that patients, when they're already in their 70s, we sometimes have limited options for being able to take care of patients, right? Because they have maybe decreased organ function, liver function, renal function. So it makes it harder for them to clear drugs. So drugs can be a lot more toxic. They also are more likely to experience febrile neutropenia and events that might be life-ending. Radiation and environmental chemical exposures are absolutely risk factors, right? So we just talked about that. Strangely enough, men are more affected than women. Again, we're not entirely sure, but we do know that men in general smoke more than women do. And there may also be some risks associated with like obesity and things like that. Again, we're not really truly sure, because a lot of these mutations occur after, someone's been alive for a really long time. So it's probably multifactorial. Persons under 55, we know that that's not true. That would be more true if we were talking about something like Hodgkin lymphoma, right? Or even ALL. So ALL is far more common among little kids. And that's, like the kids at St. Jude's, for example, when you see a lot of them going through chemotherapy, many of them have ALL. So there's some kinds of leukemias and lymphomas that predominantly affect younger people. But a lot of these diseases that we're talking about, like MDS and CML, for example, tend to affect people who are a little bit older. So risk factors for AML include which of the following? Select all that applies. So low fish consumption. Nope. That's actually for multiple myeloma, which we didn't go over. Multiple myeloma is a different kind of B-cell malignancy. It's kind of sandwiched in between diffuse large B-cell lymphoma and leukemias. Sort of one of those interesting liquid tumors. But we see that low fish consumption is more associated with multiple myeloma. What about trisomy 21? Yeah, we know that translocation mutation often increases someone's risk of developing AML. And that's actually one of the things that we look for in cytogenetic analysis when we're trying to karyotype somebody and find out which particular mutations they have so that we can make a decision about treatment, but then we can also make a decision about how to communicate to the patient their risk of relapse and also, kind of what their life expectancy is. And antecedent heme disorders. Yeah, so can anyone tell me what antecedent means? You guys are awfully quiet. Don't make me call on people, please. It's our last day together.
Isn't it just like it's like been there before, like they've had some type of problem before?
Exactly. And the types of problems that we tend to see are like MDS and CML, right? So MDS, obviously can transition to AML. There are other kinds of disorders too that may have an increased risk, but in general, we tend to see that CML or MDS can increase our risk of transitioning. P53 overexpression. Why might this not be true? What is P53?
Tumor suppressor gene.
Exactly. So if you overexpress a tumor suppressor gene, then you're likely very efficient in terms of preventing the development of cancer cells, right? So if it were P53 underexpression, then we'd be really concerned. And there are a number of different cancers, including AML, that's associated with mutations in the P53 gene. Okay, moving on. MDS patients on this DNA hypomethylating agent are likely to experience nausea and vomiting because it is a moderate emetogen. So which one?
Vidaza.
Yep, exactly. So what's funny is that Dacogen and Vidaza are literally in the same class. In fact, if you look at their molecular or their chemical structure, they look very, very, very similar. But for whatever reason, Vidaza has a much higher incidence of emetogenicity than Dacogen. So Dacogen is a minimal, right? So less than 10%, whereas Vidaza is a moderate. And the reason why I kind of harp on this is because it's really easy for people to interchange them and just make an assumption that like, oh yeah, they must be, both minimal or whatever. And so patients can end up not being prophylaxed with antiemetics properly. And the thing is that patients, when they get these drugs, are usually getting them daily for 5 to 7 days for each cycle. So you can end up having compounding nausea and vomiting potentially if you don't prophylax appropriately. So usually with these patients, when they're getting, this drug for 5 days straight, we'll give like Zofran and Decadron, and we'll do that daily because if we give the Aloxi, then you're not necessarily like you're only essentially covering for 3 days. Now, you and I know that your serotonin levels drop. So it's probably not effective to give somebody 5 straight days of Zofran, but a lot of institutions just do it because it makes them feel better that they're doing something. So we do typically prophylax with at least 2 medications, like I said, Zofran and Decadron. If patients obviously are dealing with worse symptoms or they're having breakthrough nausea, then we can make an adjustment and do like aloxia, olanzapine, Dex, or some other combination if we need to. Any questions on that before we move on? Okay. While routine CNS prophylaxis is more common in patients with ALL, which we just talked about, AML patients with CNS symptoms are likely to receive what additional type of therapy?
Intrathecal methotrexate.
Exactly. And the intrathecal installation of methotrexate can occur via 2 ways. Only one of them is truly intrathecal, but we sort of refer to both of them as intrathecal. So when you give somebody intrathecal chemotherapy, you are instilling chemotherapy in their lumbar spine, basically between the vertebral space, okay? We usually withdraw a certain amount of fluid, CSF fluid, so that we can replace the fluid with the chemo and not cause an overexpansion in that spinal canal, because it's a very tight squeeze, right? It's housing the spinal cord, and also you have all the CSF fluid that is bathed in that. We have one other option. So for some patients, we will insert what's called an Ommaya reservoir into the 4th ventricle, and the ventricles actually drain into the spinal cord and spinal column. So that's one easy way for us to give patients chemotherapy. Now, of course, you're having to give somebody a procedure to instill that Ommaya reservoir, and they have to maintain sterility and make sure that they're keeping that area clean. But for little kids, for example, and people who maybe are not able to bend in that fetal position when they're doing the lumbar puncture, who they just can't tolerate that, because it does tend to give patients a really bad headache, even if you have them lay down for about an hour or so after. But using an Ommaya reservoir is always an option. So just kind of as an aside. So intrathecal installation of daunorubicin, we would definitely not do. Intra-arterial installation of cytarabine, no, that's not really a thing with some kinds of chemo. There are some exceptions. We would never do intrathecal installation of vinblastine because it's a vinca, right? I've harped on that so much that you guys probably know that in your sleep, hopefully. And then intra-ophthalmic installation of methotrexate. I mean, I've seen that done before for some ocular melanomas, but that's not something that we're going to use to deal with the CNS symptoms. All right, and lastly,
Dr. Leva, a question.
Yeah, sure.
Number 4. So are these procedures done in an OR?
So it depends on the institution. We frequently do intrathecal, or we have done intrathecal chemotherapy in infusion centers all over the place. So normally an infusion center will have a private room or 2, like a procedure room. And as long as they're able to do it and the hospital policies don't make them go to interventional radiology to do it, we try to do it in the infusion center as much as we can.
All right, thank you.
Yeah, no problem. Now, for the Ommaya reservoir, also, that's pretty easy. It's not really a procedure because you're just literally, puncturing the stopgap, just like a port, and pushing in the medication. But it just depends on the policies and procedures. Great question. All right, a CML patient who becomes resistant to Gleevec can be switched to which of the following medications? So which medication can overcome resistance to Gleevec?
Dasatinib.
That's right, dasatinib. So they're both BCR-ABL directed TKIs, but we've been able to ascertain that at very least the dasatinib is able to overcome some level of resistance to imatinib. So that's an important thing that, we need to know, because at some point, CML patients who are on Gleevec for many, many, many years, they will become resistant. It's just a common theme. There are some new tests available too, where we can actually do specific levels of like BCR-ABL cell expression to try and pinpoint what other drugs might be useful for a patient. And there's some genetic profiling that we're starting to use too for deciding how to treat patients. So one of the cool things about myeloid malignancies is that we are actually developing a lot of new therapies for patients who fail kind of the frontline therapies, and many of them do. So it is important in this case for us to have a lot of different salvage therapies, or like, first line, second line, third line, fourth line, fifth line, sixth line. And some patients will literally have like 9 lines of therapy, either before they are cured or, unfortunately before they pass away. Now, I didn't include CAR T-cell therapy in this module. And one of the reasons why is because, CAR T-cell therapy is this like new, fancy, exciting area of oncology and hematology especially, but it's not really widely adopted yet. And it's still really used in more of the second and third line, fourth line settings. So I didn't want to get into the weeds with that, because until it becomes like a real true mainstay of therapy, right now it's cost prohibitive, and in many cases it's toxicity prohibitive, because patients will get, often will get a cytokine release syndrome that causes lasting damage and then actually can kill patients. So, that's one of the reasons why this time around it's not really appropriate. But know that CAR T-cell therapy exists. And, there's still an ongoing discussion about where it fits in therapy for a number of these different patients. They're also looking into CAR T-cell therapy for some of the other hematological malignancies like lymphomas. So, we'll kind of see where that goes as well. But right now, there doesn't seem to be much progress when it comes to using CAR T-cell therapy in solid tumors. And that may be in part due to the heterogeneity of the different solid tumors as compared to the myeloid malignancies. So anyway, any other questions before I switch over? Okay. You guys are so quiet today. You're like, I'm done. You're done soon, I promise. All right. I'm going to exit.
Dr. Leva, I know we're focusing on like Vidaza and Dacogen, but is there is lenalidomide not a preferred drug for MDS, or is it just an option that we just didn't go over?
So we didn't really go into it in great detail because we would have covered it in multiple myeloma. So I didn't want to kind of throw anything else into the mix. But essentially the things to know about it that I'm not going to test you on like the details about lenalidomide, but I do want you to know that it is used for a subset of patients. It's an immunomodulating agent that is very similar to thalidomide. And so, the only additional thing that it has that's a little bit different than some of the other drugs is that it has a very high VTE risk. In fact, it is so high that the requirement for patients who are on lenalidomide is to receive aspirin therapy. So, there are some issues with lenalidomide. The other thing is that it is part of a REMS program, and it's very well controlled, in part because it's related to thalidomide. I don't know how familiar you guys are with thalidomide, but in the 1950s, thalidomide was responsible for a number of babies being born without limbs. And so it was actually being used for like fertility stimulation, like all kinds of stuff for pregnant women. And then it was discovered that it actually is a horrible, horrible teratogen. So the same is true for lenalidomide, which is why it's under kind of tight lock and key. But for MDS patients, for example, they tend to be older. So usually we don't have the risk of like, you have to sign a form saying you're not going to get pregnant. You need to have 2 forms of contraception. You need to have, your partner also needs to whatever consent that they're going to use protection. So it's kind of a crazy thing, but I just really want you to know that it's the drug that we use for the deletion 5 mutation. Cool. Thank you. Good question. I figured you guys learned enough drugs, so I was trying to not add more to the mix. Okay. I'm going to pull up the ethics. So as an aside, did you guys find the paper interesting? Especially now that you guys have been looking at all kinds of literature and comparing efficacy of trials and things like that. So you can kind of see just based on how trials are done in oncology, why a lot of us have quite a bit of moral distress about, how drugs are coming onto the market, because there are definitely some issues. All right. So I'm going to pull this up.